All right, we will get started in about 2 minutes. It's like we have already 37 on, so that's exciting. All right, it is noon, so we will get started. Hello and welcome everyone to our webinar Lunch and Learn about measles and the MMR vaccine. My name is Mary Lizakowski, and I'm a Coalition Health Director with Foundation for a Healthy North Dakota. It is a newly established nonprofit in North Dakota with a small team. Our mission is to promote health and wellness by working with communities across North Dakota. We are building a statewide coalition to allow local communities to collaborate and work together on common initiatives. And by joining the coalition, members will be the first to know about educational opportunities such as this, the latest on relevant public health information, legislative updates, and access to digital advocacy resources and toolkits. Just some housekeeping things to let you all know about. Webinar attendees will be automatically muted for the presentation. If you have questions, please put them in the Q&A box. Our team will be monitoring questions that may come in. We will be recording this presentation and will leave time in the end to address any questions that you may have. After the presentation, a link to the recording will be sent out along with an evaluation survey to complete. It is my pleasure to introduce our presenters today. The first, Jayne Griffith, is a senior epidemiologist in the Infectious Disease Epidemiology, Prevention and Control section at the Minnesota Department of Health. She received her MA in Educational Psychology and MPH in Epidemiology from the University of Minnesota. After the anthrax attacks in 2001, she became the Minnesota Department of Health bioterrorism epidemiologist and led the development of state emergency response bioterrorism events and served as the national bioterrorism preparedness work groups. She led the disease surveillance and response component of the 2008 Republican National Convention in St. Paul and investigated a rare case of inhalation anthrax. She has responded to countless vaccine preventable disease outbreaks and emerging diseases, including H1N1 influenza, Ebola, COVID-19, and monkeypox. Before Minnesota Department of Health, Ms. Griffith was a research program manager at the University of Minnesota VA Medical Center and has been an adjunct instructor at Minneapolis Community and Technical College. So welcome. Our next presenter is Lynn Bahta. She is a public health nurse at Minnesota Department of Health, serving as the immunization clinical consultant. Ms. Bahta has 15 years of clinical nursing experience in internal medicine and pediatrics. She began her public health work in Sudan, Africa, and continued that work at the local health department in St. Paul, Minnesota. Also, Ms. Bahta worked as a nurse consultant for the national nonprofit immunize.org, which provides immunization updates and practical tools for providing best practices. With over 25 years of work in immunization, Lynn currently provides subject matter expertise to Minnesota Department of Health immunization programs, local public health, and clinicians. In addition to technical consultation, she does extensive work for Minnesota Department of Health addressing vaccine confidence and hesitancy issues. Lynn is currently an appointed member of the CDC's Advisory Committee on Immunization Practices. It's such a pleasure to have you both here joining us today, and I will turn it over for Jayne to share her presentation.
Thank you, Mary. We're excited to be here today. So we will get started. Lynn, are you able to share?
You should be able to see it now.
Yes.
All right. I am not seeing the presentation.
I can see it being shared.
Let's see if I can. I wonder if I can, I have an option to request remote control if.
Or did you want to share? Or I can share as well.
Maybe Mary, if you would like to try to share. Otherwise, I can certainly pull up the presentation on my end and at least see the presentation. And Lynn, if others can see yours.
Sure, we could do that.
All right, let me just pull this up here.
Okay, you should have control to pull up anything.
All right, so I will not request control, but I'm assuming, Lynn, now everyone can see your screen except for me.
I'm assuming that is the case, yes.
All right, so we will get started then. So again, thank you everyone, and we're really excited to be here. Just gonna go over quickly our objectives for today, and it seems like a lot, but we'll be happy to take questions from you as well. So number one is we want to be able to describe the epidemiology of measles in various populations, including vulnerable populations. We want to explain the possible clinical conditions that are associated with the disease, including serious complications, impact on quality of life, and risk for vulnerable populations. Number three, identify the patients for whom vaccination is a priority based on age and medical comorbidities. Outline current vaccination rates in older adults in the United States overall in North Dakota, and talk about strategies for improving the uptake of the vaccine for the disease. Number five, describe and compare any vaccines currently available in the US, including safety profiles, efficacy, dosage regimens, and costs. And number six, at the end, we will provide an example of a disease outbreak. And next slide, please. So I will just give an overview here of the disease itself. Next slide, please. So measles is not a trivial illness. It's a very serious illness. It's caused by the measles virus. Cases get very, very sick with it. It starts with a high fever, and then patients typically get a cough or a runny nose or red eyes. So we refer to those as the 3 C's: cough, coryza, and conjunctivitis. And then after a couple of days, a maculopapular rash starts at the top of the head, sort of the hairline, and descends downward. It is a vaccine preventable disease. The vaccine is 93% effective with 1 dose at between 12 to 15 months of age. And then it's 97% effective after 2 doses of the vaccine. Measles is spread by the airborne route. So when people cough or sneeze or cry or even talk, viral particles expel and can float in the air for up to about 2 hours after a person has been in a room. It is one of the most infectious viruses that we know of. There's about a 90% attack rate in susceptible close contacts. So that means 9 out of 10 people who are exposed to someone with measles who are susceptible will get it. There is not a specific treatment for measles, but there are medications available for symptom management like dehydration or diarrhea. And then, of course, antibiotics can be given for secondary infections like a bacterial pneumonia. And then hospitalized cases are recommended to get vitamin A therapy to reduce the risk of serious complications or death. Next slide, please. So just a glimpse of what measles looks like globally and in the US. Measles is a huge concern globally. There are about 40 million children that are at risk of contracting measles due to declining MMR vaccination from the COVID-19 pandemic. Measles is a leading cause of vaccine preventable deaths in children under the age of 5. And just in 2021, it was estimated that about 128,000 people died from measles, and the vast majority of those were children. In the United States, measles was declared eliminated in the year 2000, and that means that we did not see continuous transmission for at least 12 months. So that's the measure of that's the measure of it, indicating that it's not, endemic in a country. However, recently, we're starting to get a little concerned about maintaining this elimination status because in 2019, we had some large outbreaks in the US that resulted in continual month-to-month transmission. We were up to about 11 months holding our breath to see if we were going to go into 12 months. And fortunately, the cases stopped. So this is becoming a very large concern that we could soon lose our elimination status. In Minnesota, we see about 1 or 2 cases per year. And of course, we're very concerned about maintaining our herd immunity with high vaccination rates so that we, will not be in a situation where there's sustained transmission. Next slide, please. So again, just looking at the benefits of vaccination, looking at data from the year 2000 to 2018, it was estimated that vaccination prevented 23.2 million deaths worldwide. And concerningly, from 2016 to 2018, just in two years, measles cases worldwide increased by nearly 170%. So again, this is very, scary information. We know that measles is really taking a hold in some areas of the world. Next slide, please. So if we look at the number of measles cases in the United States, the far bar on the left is 2010. And you'll just kind of note that we're in this gradual kind of upward trend of sort of these big outbreak situations. So the first kind of big jump there is in 2014, and there were almost 700 cases that occurred that year. And an outbreak was initially seeded at Disneyland. You may have heard about that, where an infected traveler infected many other visitors to Disneyland, who then went back to their various states of residence and infected others. And then again, you'll see a very big bump in 2019 with almost 1,300 cases. That was the year that I was referring to, where we almost lost our elimination status. And that year saw very big outbreaks in New York City, New York State, and then Washington State. Next slide, please. So, of
Hey,
course,
Jane,
do
you have Teams on?
I disconnected it, and
Oh,
it's
okay.
still, yes. And I, if you have any suggestions, but I've completely signed out. Yeah, so sorry.
Okay.
Yeah. So measles, in terms of who is affected, again, anyone who is susceptible is at risk of getting measles. So anyone who has not been vaccinated or has had natural disease. On occasion, a vaccinated patient will get measles, but they get a very mild case of measles. Children under the age of 5 and largely infants are at great risk of severe illness, and adults older than 20 years are also at risk. But again, the highest death rate is in infants. And then there are certain populations that are at risk of severe disease in addition to the infants, and that would be immunocompromised persons and pregnant women. And in fact, tied to the outbreak, the Disneyland outbreak in 2014, although his death occurred in 2015, was an immunocompromised person who was exposed to measles virus in a medical setting. The person, had been vaccinated, but was taking immunosuppressive drugs and was therefore susceptible to measles virus, and then ended up dying from measles. Next slide, please. Okay. So we work a lot with our clinical community to, make sure that providers know that if they're seeing a suspect measles case, that they need to contact us, because again, we want to, go over their clinical suspicion, the symptoms, and make sure that all infection prevention steps are being taken. So a suspect measles case, of course, there are many rash illnesses, but a suspect measles case is one that has this maculopapular rash that started, kind of from the hairline down, has a fever, and at least one of those 3 C's. So at least a cough or conjunctivitis or coryza, cough, red eyes, or runny nose. And then we also talk to the provider to ask if the patient has a known exposure, maybe their sister, has measles, or if they've had recent travel. And that all, kind of increases our concern for measles. We work with the provider to make sure that we get the proper specimens for testing. And then we, remind the provider to tell the patient that they need to stay home and stay isolated. And so this process is like really important because, you know, of course, anytime we have a measles case, it's a public health issue, and we don't want to find out about a measles case for the first time when we get that result. We want to kind of know when these patients are being suspected, so we can kind of get all of our ducks in a row and make sure the patient stays home and isolated. We can work with the medical facility kind of before that diagnosis is made to make sure that we're assessing, you know, for any suspect or any potential patients that may have been exposed. Next slide, please. All right, so in terms of, you know, what does hospitalization and complications look like? Measles results in, you know, kind of a high proportion of cases being hospitalized. Again, you know, many of the cases are in children. You know, as I mentioned, they tend to get severely ill. When we look at national data, about 25% of cases nationally are hospitalized, and nationally about 30% report complications. And those complications can be, you know, like diarrhea, dehydration, ear infections, pneumonia, sort of rarely encephalitis. Death can occur in the rates of 1 to 3 measles cases per 100,000. And then there is another kind of fatal complication that occurs some years after a child has measles. It's the initials here, SSPE. It's subacute sclerosing panencephalitis. And it's thankfully very rare. It's essentially a brain inflammation that there's no treatment for, and it is fatal. And in Minnesota, our data indicates that our cases tend to be hospitalized a little bit more frequently than the national data. In our 2017 outbreak, we had about 28% of our cases were hospitalized, again, for these common symptoms of complications of like dehydration and vomiting, and then, you know, typically pneumonia. And then this past year, we had a number of cases. We had 22 cases. It wasn't an outbreak situation, which I will mention in a couple of slides, but 45% of those cases were hospitalized. Again, you know, kind of these same typical complaints. The hospitalizations typically, you know, are for a few days, can be as long as a couple of weeks. And as you can imagine, this is very disruptive for a family. And also, you know, typically, you know, families with children, we have to exclude their other children from going, the exposed children from going to school or daycare. And then a family may be trying to manage keeping those kids isolated while having a child hospitalized. So it's very stressful and very disruptive for families. Next slide, please. So here are just some of the different images of measles rash. The rash again starts at the hairline and descends downward. These kids, you know, when they present, oftentimes when a provider tells us the child looked really punky or they look really, really sick, that, you know, sort of non-medical description really raises our suspicion that the child has measles before we get the test result, because they appear very, very sick. Next slide, please. So this is, again, just a graph of the measles cases that we've seen since 2004 until this year. And you'll see a bump in 2011. It's our first bump where we had an outbreak that resulted in 26 cases. And we thought that was really kind of a once in a lifetime event. And lo and behold, 6 years later in 2017, we had a huge outbreak of 75 cases. And then last year we had a situation where we had 22 cases, but it was not an outbreak situation. We had just various importations of patients who were exposed to measles outside of the country who returned and infected others. Next slide, please. So again, to underscore, because the United States is in a situation where endemic measles has been eliminated, our measles cases are tied to travel. So typically what happens is, unvaccinated children will travel out of the country, and get exposed while they're out of the country, and then either come back as they're infectious or return to their home state right before they become infectious. And when we look at our data from 2000 to 2022 of our 146 cases that we've had during that time period, 25% or a quarter of them were directly infected overseas. And then 74% of those were like siblings or classmates or daycare mates or neighbors that were infected from those initial cases. Next slide, please. So this is an epi curve of our outbreak in 2017. And I wanted to show this because this is kind of a typical scenario where, a traveler comes back, has measles, and by the time public health knows about it, others have been infected. And so it's sort of already on like seeding in the community by the time that public health knows about it. So this figure starts at the end of March 2017. And we actually didn't know about the first 3 cases, those first 3 little bars, until that peak, that bar with the blue line where it says April 11th, MDH becomes aware of an outbreak. 2 cases were reported and confirmed. Well, this was very odd to learn about 2 cases of measles on the same day in children who were unrelated. And we were kind of stunned at that point because we wondered what was going on. And after conducting interviews with the families, we learned that both children attended the same daycare. And then in kind of retrospectively looking for cases, we identified these other 3 that we did not know about until we got them in for testing. And so by then, this is the scenario that everyone is afraid of when you kind of don't get brought into a situation early enough to kind of take these preventive measures. This outbreak was seeded. And it basically took through June of that year to get it under control. We had 1 remaining case in July of that year, and then we have to wait for 2 incubation periods following that to make sure that the outbreak is over. But this was an outbreak that was extremely disruptive to many families because many daycares were shut down, impacting parents' abilities to work. And again, the period for an exposed child being out of school or daycare is 21 days. And, typically a parent needs to stay home to take care of that child. So it's just economically very, very hard on these families. Next slide, please. So this is a very unusual figure here showing our unusual situation from last year. So last year we had these 22 cases, but we did not have outbreaks associated with them. And so we had our first 2 cases identified last June, and they were in 2 siblings that returned from overseas. No further cases. They were sick basically the next day after they returned home and saw the provider. The provider called us. We got everyone isolated, and that was the end of that. In October's a very similar situation. A family returned from overseas, and 4 of their children were ill. Then in September, we had 2 different families returning in September. Each family had 4 children that were sick. Now, note this was September, so what happens in September? School starts, and so we had a couple of the children attending school during their infectious period. And so we had to work with their schools and identify exposed kids and teachers so that they could stay home and be isolated. And then in October, we had another family that returned, again with 4 household members ill, and then also 2 more siblings from the first September group became ill. Next slide, please. So again, all of our cases in 2022 were unvaccinated. Almost half of them were hospitalized. Again, the same kind of complications: ear infections, dehydration, vomiting, diarrhea. And the cases here were again related to direct travel, with a couple of the siblings who didn't travel, getting exposed, and there were a couple of cousins. And then again, primarily these exposures to the cases here in Minnesota occurred in school settings. Next, please. So we, were curious last year, looking back at how we were so fortunate that nothing morphed into outbreaks when we had these different sort of introductions of measles. And we wanted to kind of reflect as to why were we lucky that we did not have these big outbreaks. And largely, we have such a relationship built up now with our healthcare providers and our healthcare infrastructure, because we have gone through these outbreaks quite a bit. And we work a lot with our healthcare providers. Again, for this recognition of measles, we work with the infection preventionists, to help identify even like other kids in the family who might be coming in to a healthcare visit who don't have measles, but we, work with the healthcare system to kind of put alerts, so that they can take infection prevention precautions with them. We also, again, have done this a lot now, that we can identify the exposed and susceptible cases pretty quickly, so that we can offer them post-exposure prophylaxis, either vaccination or immune globulin. We make sure that those who are still susceptible are isolated. And again, we just have really good networks, with our healthcare providers, schools, daycares, local public health, because we have been through this, unfortunately, a lot. And next slide, please. So our kind of overall message is that measles outbreaks are super disruptive to the patients, to their families, to the communities, the healthcare facilities, public health, schools, daycares. I mean, everyone. Is just really, really a tough situation to be in. And again, we just really wish we did not have to be in this situation, if we can get our vaccination rates up. And that's it for me. And I will turn this over to Lynn.
I'll just step in and say one thing. Thank you for your patience, everyone. We are trying to work on the back end on the tinging noise, but I think we figured it out.
Good afternoon, everyone. I'm going to talk a little bit about MMR vaccination and why that's important. Jayne, I think, has introduced you to that concept and the many cases and the many deaths that have been prevented through vaccination. So let's dig a little deeper into the MMR vaccine. The MMR vaccine is the vaccine that we have in the United States. So it is a combination of measles, mumps, and rubella. And we have two products that contain those three disease vaccines against the disease, MMR2 and Priorix. Those are the brand names. The listing of these brand names does not necessarily mean endorsement outside of encouraging people to get the MMR. And I think it's important for us to be aware that MMR as a combined vaccine has been used since the early 1970s. So we've kind of celebrated that 50-year anniversary of MMR. And that suggests to us that we have a really safe and effective vaccine. We've seen the drop in measles disease, rubella disease, and mumps disease to the point where when we get a case, it is an emergency. We want to know where it's coming from. For these two products, the recommendations are the same. And so we also have a combined measles, mumps, rubella plus varicella vaccine called Procod. So that is a third product that's licensed for kids ages 12 months through 12 years. The MMR products are licensed for 12 months and older, although we do have some off-label recommendations for the use of MMR and Priorix. So one of the things that we saw when the Procod, the MMR, combined with varicella or chickenpox, it initially came on the market, was that children seem to have a higher rate of fever seizures or febrile seizures in that first 12 to 15 month dose that is for when the vaccine's recommended. And so because of that, the recommending body for immunizations, which is called the Advisory Committee on Immunization Practices, or ACIP, recommended that at that age we not use the Procod unless a provider has actually talked to the parent about that incidence of febrile seizures, and to give the MMR and the varicella separately. Most kids will get the combined one with their second dose. So what is that schedule? For children, there is no specific population that should be getting this or not. It is a routine recommendation that all children receive the measles, mumps, rubella vaccine. And the first dose is given between 12 and 15 months of age. And that second dose is typically given between 4 to 6 years of age. Kind of that school entry time when kids are returning into a more compact environment with other students. But the MMR can be given as soon as that second dose can be given as soon as 4 weeks after the first dose. And we do take advantage of that during a measles outbreak. When we are seeing a lot of measles, we will recommend that children who've received their first dose should, if it's been 4 weeks, get a second dose. What it does is close up that percentage of people who may not have responded to the first. So as Jayne said, after that first dose, we see 93%, meaning 93 out of 100 kids will develop immunity against measles. With that second dose, that closes that gap to 97, in some instances even a little bit higher. And so because this is such a contagious disease, we want to make sure that we're capturing even those children who may not have responded to that first dose. So there are some special situations where we do vaccinate when we have children who are as young as 6 months. So too young to really start their routine MMR vaccination. They are recommended to get an MMR dose and all the way through their 12 months of age. But it is important for people to, and parents especially, to realize that this is an extra precaution. We can't always guarantee that that infant will develop protection from that dose. But for those that do, it will protect them during their travels. And so once they reach the age of 1, they will need to start the routine childhood series. So they're going to be revaccinated with the first dose and then get that second dose as they go into kindergarten. And then if children are traveling and are 12 months or older and have only received the 1 dose, they should get that second dose early if it's been 4 weeks since their first dose. And again, that's to add that extra insurance to protect these children against a highly infectious disease. Most adults have had at least 1 dose of MMR, and some of our younger adults will have had both doses. But we want to make sure that our adults coming into clinics have been assessed for documentation of at least 1 MMR or have some evidence of immunity. And that can be a variety of things. If they've got a provider that has written a note saying that they had a diagnosed case of measles, it's been confirmed by lab, or if they've had laboratory tests and the lab tests show that they have antibodies against measles. There are certain adults that should get 2 doses of MMR, and specifically people going into college need to make sure that they've had 2 doses of MMR. People working in the healthcare setting should have evidence of 2 doses of MMR, and those traveling internationally. Again, these are all situations where in college you have congregate setting, and in a healthcare setting and travel, you may have an increased risk of exposure to measles. Excuse me. There are some people who should get the MMR, specifically people who may have had a really bad reaction, meaning it was a life-threatening reaction from a previous dose or to one of the vaccine components that's found in the vaccine. People who have severe immune deficiency. So they have a weakened immune condition, either because of some illness that they have or some treatment because of an illness that they have. And so typically when this vaccine, which is a weakened live vaccine, but can cause severe illness in people who have a weakened immune system, we just don't give those live vaccines to them. Pregnancy is another time. And the biggest reason we don't give it in pregnancy is because of the rubella component of that vaccine, where rubella syndrome is something that can be a risk for infants. This is theoretical. In the monitoring of this vaccine, and in monitoring women who may have inadvertently been pregnant when they received an MMR vaccine dose, we have not seen any increase in severe outcomes compared to a typical pattern of pregnancy. So we don't think that it's a problem, but we don't want to take the chance. So pregnancy is a reason to not give the vaccine until after the pregnancy is complete. And then for young kids, where there's a family history of someone with a weakened immune system, they should be further assessed before clinics go ahead and get those young children vaccinated. And then there are some reasons we want to delay vaccination. These are the precautions for children who may have received an antibody-containing blood product, and that includes something like immune globulin. And that's something that we here in Minnesota, having worked through some measles outbreaks, have had to pay attention to, because when we are doing those case investigations, and if there is an option for a young child to receive immune globulin, and these are children that are younger than 12 months, they need to delay the receipt of their MMR longer than if they hadn't received those blood products. A history of a condition, a blood condition called thrombocytopenia or thrombocytic purpura. And what that means is it's a deficiency of our some of our clotting factors where we can't clot. And this typically is a self-limited issue, but it can occur. We know that one of the side effects of measles vaccination, which is very rare, but it does happen, is thrombocytopenia. So if there's a history of that, we need to make sure that we are weighing the risk of a recurrence of that thrombocytopenia against the benefit of getting protected from measles. And again, measles itself can cause thrombocytopenia. And so we're looking at risk and benefit So I think that this is something that gets discussed with the clinician and the parent for their child. When TB testing is being conducted, there needs to be coordination of timing. So if you've been vaccinated, you need to hold off on the testing because it can interfere with the results of the TB testing. And then kids who are moderately to severely ill at the time that they're due for their vaccine usually should wait until that illness has is on the way to being resolved. They don't have to be completely symptom-free, but if the course of the illness has taken its course, they can go ahead and get vaccinated at that point in time. We have several side effects that are very common, some side effects that are rare and or do happen, but not as often, and then some that are very rare. And the most common side effect that we see, typically we begin to see it around day 5 to 7 after a child's received their vaccine. Again, this is a weakened live virus, so we're trying to get the measles virus from the vaccine to duplicate itself so that our body, our immune system recognizes it and can create antibodies against it. And that time of recognition and creating the antibodies is when someone starts having symptoms. It's kind of like when you feel sick, you have symptoms, things like fever, feeling tired, you might feel achy. When you're giving this to young children, they may not have much of an appetite. So these are things that will resolve over a few days, and the child goes on to be protected against measles. Occasionally, with the fever, you might see children developing a rash. Again, children who have been vaccinated who develop a rash are not infectious. It's their body responding to the weakened vaccine that they've gotten. And because of the mumps component of the MMR vaccine, you may see kids who get the swelling behind the jawbone because of the mumps portion of that vaccine. Again, there are rare side effects. One is seizures that are caused because the child has fever. And the other is the thrombocytopenia, where a child may bleed easier than you would want them to. And that just needs to be monitored to make sure that it doesn't become more serious or worse. Usually, again, these are both very self-limiting. The seizures only occur because of high fever, and the bleeding usually runs its course and the person recovers. So when we think about our risk for outbreaks, again, high immunization rates are going to be the most important thing that we consider when we are doing trying to prevent measles disease. And we need to see coverage rates greater than 90 and ideally even above 95% in order to really avoid outbreaks happening in our communities. And so the state of North Dakota, the state of Minnesota, within the immunization programs, they are monitoring these coverage rates. And I just thought I'd throw this up. This comes from the North Dakota website, but this gives you an idea of the immunization rates for children who are between 2 and 3 years of age, and how well they're doing for that. And so you can see that the green is good. Green means go, I'm guessing. So for the most part, the state is doing pretty good. But it doesn't tell us a whole lot. We have to maybe get a little more specific. The blue, what's going on there is their access issues. So it gives us a clue that things are going well in some areas and maybe not so much in other areas, and that we need to figure that out, what's going on there. Also, I pulled up the data from the CDC website for North Dakota among our adolescents. How many of those adolescents are covered with 2 doses of MMR? And North Dakota does a great job of getting those doses into their children. And a lot of this is the benefit of school laws. It's getting our children protected so that the school doesn't become a point of infection for children, especially for measles. But North Dakota's rates are high and above the US level. And so a shout out to all of you who work to vaccinate children for these 2 doses, and to the North Dakota State Health Department for the work that they do to ensure that that is happening. I wanted to just show you in Minnesota, we do the same thing. And we look at our infant rates, and again, we look at our kindergarten rates. We'll look at our teen rates. This happens to be kids who have been vaccinated with at least 1 dose of MMR by the time they turn 2. And so we're seeing rates in the mid 80s to 90s. We would like to see that much higher. We want to really meet our national goals. And so we've got some work to do. And when we see this, we begin to think about, okay, where is this happening? What do we need to worry about? And we begin to look at where are the disparities. And so that is something that has been part of our world here in Minnesota, is looking at and addressing disparities in vaccination coverage rates. And we've worked with healthcare systems, we've worked with the Department of Human Services and our Medicaid populations to try to get a more robust picture of what's happening with our children and with our various racial and ethnic groups. And this is something that we have been doing and been able to do over the last couple of years, as we have partnered with many more systems to get good immunization data for COVID. We've been able to get similar data for our childhood vaccination rates by ethnicity and by race. And you can see that we've got a couple very significant disparities, one among our Black, non-Hispanic ethnic groups and among our American Indian, Alaska Native, non-Hispanic groups. And so these are red flags to us. What's going on? When we look more grossly for MMR coverage, we see that many are areas of Minnesota divided out by our race and ethnicities are doing very well. It's very we can't really see what's going on, but when we look at our Black non-Hispanic layout, according to regions, we're seeing some lighter blue. And so we again are wondering what is going on here and what should be done to mitigate that. And that's where having an outbreak became a signal for us. And the outbreak that we had in 2011 impacted disproportionately children of Somali ethnicity. And we had been hearing up until then some anecdote about refusal of the MMR vaccine. And this takes us all the way to this spring where we're seeing rates of 30%, which is breathtaking. It scares me. It's not a matter of if we're going to have another outbreak, but when and what kind of things that we can do. So I'm just going to do a little bit of talking about what kind of work we've been doing in this community. It's something that all of us can adapt with, whether we're community advocates trying to promote immunization, if we're local health departments, or if we're clinics serving populations. What are some things that we can do? And just to give you a little more background, it was in the summer of 2008 where we started to hear hesitancy issues raised by a couple parents who are of Somali ethnicity. And one of the parents said in a TV news coverage show that it was the vaccines that was the problem. And I remember hearing that and thinking, oh, this is a problem. If we have parents who have decided it's the vaccines, how is that going to impact the broader new American community? And in this instance, our Somali community and our Somali Minnesotans. And some of the issues was a buildup of things where parents were very overwhelmed because their children they were seeing many of their children get autism, and they saw them taking over some of the special education programs, and they were convinced that there was something unique about them and unique about what was causing that. And they started to seek help from the Department of Health to find resources, but they were also looking at what is causing autism. And they linked up with a couple groups from the national level who had previously made claims that autism was caused by MMR vaccine. And these groups actually came into the community to provide support to these parents who were feeling very overwhelmed. And that support that they gave really built a trust between these anti-vaccine groups and the parents who were looking for support and feeling very isolated because they didn't know what was going on with their children. We began to start hearing more and more anecdotes from our clinicians that parents were refusing MMR vaccine. And it was in 2011 when we did have cases of measles, and particularly among our ethnic Somali children, where we actually looked at our MMR rates. And that was what we saw was this. And at that time, we had data to this point. And so we were seeing immunization rates at around 69, 68%. And so we weren't surprised that that was happening. But again, we, as a health department, we really needed to respond. And so our approach was very broad strokes. We put out some information campaigns, and we used some of the diverse media, especially radio and translated written material. We distributed travel information to different travel agents that would make travel arrangements for our Somali community, going back to Kenya or back to Somalia. And we actually developed a couple videos about travel and immunizations, and the Mayo Clinic had a YouTube video on immunizations and autism. The problem is that we didn't have a way to disseminate this within the community. We didn't have people that we knew that could do this outside of the few connections we had with radio stations and written newspapers. And so our broad approach was really very, very ineffective. And you can see from the graph that I showed you about the rates that they continued to fall. And so we really needed to figure out, how do we bring in the community? And we actually hired staff in full-time positions to work on this issue and work within the community. One who did a lot of work with the leadership in the community, another who did a lot of work with the parents as an outreach educator. We also created some internal working groups to address this. This wasn't just an issue for the immunization program. It was an issue because it was being driven by parents' fear of autism. And so we needed to make sure that we were fulfilling a need that wasn't related to vaccines, but related to how can we support parents who had children diagnosed with autism, and how can we get those diagnoses earlier? How can we help them understand? And so we also pulled in our state communications office. But most importantly, in hiring our colleagues, we listened to what they had to say. They know where the gaps are. And they really helped us build a much more cultural competent group of individuals to tackle this issue. And we focused our strategies on engaging the community, especially community leaders, developing partnerships with some of the community-based organizations. We also worked on both informal and formal training and outreach, where we would come into a child care center and offer to give an hour, 2-hour session on immunizations and child growth and development. And then among our epidemiologists, we really worked at monitoring for cases and figuring out ways that we could mitigate when a case did occur. And I think Jayne aptly described some of the things that led to a lot of that work. We did a lot of learning. And one of the things that we learned is that parents who are worried about vaccines, especially in this case, worried about the MMR vaccine causing autism, really needed an opportunity to purge their questions and concerns. So that broad YouTube thing doesn't satisfy that. They don't have anyone to talk to about their worries. And that seemed to be a very important thing. So we did a lot more smaller group type of education, thinking that because our Somali ethnic community here in Minnesota has a very strong oral tradition, a lot of that information could be spread by word of mouth. And so we would teach small groups of parents who felt comfortable asking the questions because there weren't so many people. And then they would go out and tell their families and their friends what they learned. We needed to encourage our clinicians to have discussions and to start that discussion early. And we needed to make sure that we were adapting to some of our younger audiences, where we needed more non-written material for our older community members. Younger mothers did speak English and were doing a lot of Googling. So we needed to make sure we were sending them to sites where they could get good information. And with this approach, we saw a slowdown of the decline. It was still declining, but at a much lower rate. And we nearly leveled off our decline, and then we had our 2017 outbreak. And the good news was that we were able to respond quickly. Because of the work that our two colleagues had been doing to establish relationships and partnerships, they were able to respond very, very quickly. And because of the work that our epidemiologists have done with the healthcare systems, they were able to respond and pull in kids to get in, post-exposure prophylaxis, or getting them in for vaccination if they hadn't been. And I think the biggest thing is the work that we did in the community, where we knew the rates were low and we knew that an outbreak was inevitable. And so it really took all of those partnerships to respond. And we saw a huge swell of cases between April and May, and that really began to taper off in June, despite the fact that that was Ramadan and that was a time when a lot of community members were gathering together. They knew to be much more cautious about that because of all the outreach that was being done by the community itself. We did a follow-up study because we saw in our data that there was a significant rise in vaccination. We saw about 12% increase from a 42 to 58.9%. And so what we did some one-on-one conversations with a lot of the parents about what changed your mind about getting vaccinated. And they really emphasized the fact that before the measles outbreak, the only threat to their child that they felt was relevant was the threat of autism. And because there was no measles in Minnesota, that was the urgent threat. But when measles came into Minnesota, they realized that that could be deadly for their child, and they chose to go ahead and vaccinate. And so there was very reasoned weighing of risks and choosing to protect against measles during that time. And we also learned a lot about the families' experiences in the clinics, which weren't always complimentary. And we've used some of that information to share with our clinical partners so that we can have a more friendly environment, a more informational environment when these community members bring their kids in for their doctor's appointments. We're continuing to do a lot of outreach in childcare centers and training. We're trying to amplify the efforts that we've done and are working with our local health departments, providing some funding to have them hire staff that are relevant for their community if they have a large population of Minnesota Somali members, that it's important to make sure that they have representation of that community within their work environment. And we're beginning to explore coverage in other communities as well. And the pandemic also gave us a chance to create a more efficient model for addressing health equity and reducing disparities. And we basically, there was a specific branch that was formed and staff that were hired from the multiple communities that we have in Minnesota, and they became liaisons between the community and the subject matter experts to provide information both ways and conduct some mutual problem solving. So these are the key takeaways in the work that we've done. And again, you saw that the work is not over. We knew that we were not in a sprint, that this is a marathon. And as my colleague once said to me, when the lie gets out, the truth cannot catch it. And that's kind of where we're at. But we are working to build trust, build capacity for cultural competency, and fostering that cultural competency. We can't be making assumptions. We need to take on an attitude of humility and think, well, we quickly want to translate this piece of material, and we need to think, well, is that appropriate? Who's that piece of material for? And do they read, can they read that translation, or would a different type of media be better for them? And we need to trust those that are representing the community, that they may have a way that achieves the goal better than what we might be thinking. And that we just need to be listening, and that we need to make sure we're listening to more than one voice, that one voice in a community doesn't represent the whole community. And so it's important not to wait for an emergency. It's important to learn within your communities who has that inherent credibility. And it's important to set up contracts with media that serve that community, and to learn what works so that the information that's getting disseminated is understood and can be acted upon. And that includes understanding cultural norms, beliefs, values, what's important in a community. Where does the community congregate? So where could the threat be in spreading disease, depending on what that disease is? And where can we provide that information? What settings work? And that we all need to be advocating for competent interpretation services. In our situation, we had a community where English for many members was a second learned language, and that can create gaps in understanding, especially medical terminology. But we need to make sure that what we're doing is done at the highest level of excellence, so that we are getting those messages across. And to consider, if we aren't members of the community, it's important for us to take a position of learning, to be a buffer against a lot of the bureaucracy that can occur, and very generous in sharing what you know, so that they can be empowered to do the work themselves. And with that, well, thank you.
Thank you. I really liked your key takeaway principles. And I think those are skills that we can use as we work with our communities in North Dakota. So thank you for sharing those. I'm going to share my screen quick if you want to unshare yours. And okay, so we are a little past time, so we don't have a lot of time for questions. And I don't know if any came in. I'm just looking here. I don't see any that came in. So I think what I can do is people can submit their questions on the survey. There is a spot for comments. So we welcome the questions in the survey, and then we can follow up with each individual. So thank you so much to our presenters for being here and taking the time to present, and to all the attendees. To stay connected with us, we welcome you to follow Healthy NODAC on Facebook, Instagram, Twitter, and Foundation for a Healthy North Dakota on LinkedIn. And also to join our coalition, visit the link to stay aware of future webinars and updates on the foundation. And also on this slide is the QR code, so you can take the evaluation survey. It will be emailed out as well. We also would like to hear from you if you have a story to share. We value the stories of the community members. If you know someone or have a story to share yourself on how a disease impacted your life, you can contact me or leave a brief message within the evaluation survey. There is a designated question for this, and we will follow up with you. So thank you again, everyone, for joining, and have a great rest of your day.